So as we know, most patients that enroll in hospice do so at a time very near their death. But significantly, there is a minority of patients, nationally 12 to 15% annually of hospice patients, that live beyond their expected 6 months or less prognosis. These pose a considerable challenge to both the clinical realm of care in hospice and also the regulatory realm. So this session explores three main areas. One, the relationship, similarities, differences between prognostication and prognostication science, and eligibility, Medicare hospice benefit eligibility guidelines, and all their complexity between the two and what's evolving over time. I think the take-home point for that section is if you're a hospice medical director, it's prudent to be really a lifelong learner in prognostication science. As important, it's also important to focus on eligibility requirements. The second section involves the regulatory scrutiny environment, particularly audit environment, both from its complexity and discussion to why they continue to be very focused, particularly on long length of stay patients in hospice. I think the take-home point there is a topic I usually talk about, which is regulatory auditors fundamentally focus on data and information. They have a patient chart. That's what they look at. They look at the data and information. On the other side, the hospice care team, and for that matter, the hospice medical director, focuses on people, a patient and family. So they don't always mix, but the reality is as important to focus on people as particularly focus for the hospice team and the hospice medical director on documentation, clearly defining eligibility for a patient on a regular basis. The third section involves practical discussions on clinical and regulatory focus. So the important aspect of prognostication and eligibility, clinically speaking, is really trying to develop within your hospice a process and a culture and utilization of prognostication tools and understanding of the eligibility guidelines that are usually mandated through what we call LCDs. So looking at LCDs and the guidelines, I think it's important to not approach them as a barrier to finding eligibility, rather as a tool. So in conclusion, I think, again, it's extremely important for hospice medical directors particularly to lead forth in their hospice to better understand prognostication science, to better respect and utilize eligibility guidelines as tools to help further discussion on eligibility versus barriers. I think it's also important to develop a hospice culture where not only at recertification periods you're discussing whether a patient should continue hospice eligibility, but really do it on a day-to-day basis amongst the whole team. Fundamentally, the doctor, the hospice medical director, will sign the dotted line, but getting the team involvement is critically important to, again, do the best care we can for our patients and families.